Welcome everyone to our ISN-Eastern and Central Europe Regional Board meeting, part 2. A couple of days ago, we had the part 1, and we're discussing the KDIGO 2020 guidelines for treatment of glomerulonephritis. And we're discussing what is new. Today, I'm also happy to have very esteemed speakers from the region who will share their experiences and knowledges with us. And as the ISN region, we are indebted to the ISN headquarters making this webinar go on live. And I'm also thankful to our esteemed speakers, colleagues who are with us tonight. And couple of logistics, please use the chat box or question box to send us our questions. And we will be discussing at the end of the session. I will have all of our speakers give their lectures, and then we will discuss about your questions. And we cannot manage it in the meantime given to us because we have 90 minutes to be with you. We will be happy to answer all of your questions in the coming days or hours. Actually, what happened was last time we answered them in hours. Now, let's start with Professor Annette Bruchfeld from Sweden. She's from Linköping University, Karolinska University Hospital, and she will be talking about our great diseases, minimal change disease and the FSGS, and what we have on the pipeline as new treatments. Please.
Oh, thank you. So I will talk about the KDIGO treatment guidelines update in 2020 about glomerular disease and focus on minimal change and focal segmental glomerulosclerosis. So these are my disclosures. So these are podocytopathies that we are discussing. These diseases, primary minimal change disease and focal segmental glomerulosclerosis. And they usually present as nephrotic syndrome. And kidney biopsy is essential in adults for diagnosis, but not necessary for children until treatment fails, because in children it is assumed that 80–90% of them have minimal change disease if they present with nephrosis. So glucocorticoid treatment is a cornerstone of the initial therapy. And there are a number of pathophysiological hypotheses, what lies behind the diseases, from T lymphocyte dysfunction and also B lymphocyte dysfunction, and a number of genetic loci that are involved, and also genetic background to the diseases, and also circulating permeability factors which altogether alter the podocyte and leads to proteinuria. And you can read about this in this review paper that came out recently in the Autoimmunity Review. So just to define the response criteria, because this is fairly important in these diseases. So the nephrotic syndrome, that is of course well known, that you have heavy proteinuria, peripheral edema, and hyperalbuminemia and hyperlipidemia. For a complete remission, all of this has to be reduced greatly, less than 0.3 grams per day of proteinuria, normal serum creatinine, and a serum albumin that is basically normalized. Partial remission is a reduction of proteinuria also, but to a lesser extent, and at least a decrease of 50% from baseline, and a stable serum creatinine, and a change of creatinine at least of less than 25%. Then we come to these, the problematic patients are the steroid-dependent patients who will have relapses during or within 2 weeks of completing steroid therapy. Steroid resistance is persistence of proteinuria despite high doses of prednisone for an extended period of time, usually more than 4 months. And then frequently relapsing patients are patients who have 2 or more relapses within 6 months, or 4 or more relapses within 1 year of achieving remission. So the approach of the KDIGO in 2012 was this grading system of level 1 being we recommend and level 2 being we suggest, and then there were all these gradings with letters. The quality of depending on the quality of evidence, from A was high, B moderate, low, and very low, depending on what was shown in the literature and how sure you could be to recommend these approaches. In the new guidelines, you have more practice points, which is and this is to help the clinicians to better implement specific advice or aspects of care, also where there is limited evidence. And should be used as this represents expert judgment of this guideline work group, but it may also be based on limited evidence. And these are not graded for strength of recommendation, quality of evidence. And the user should use this as practice points, as expert guidance, and use it as they see fit, depending on where they are and what is practical for the clinician in a specific practice. So minimal change nephropathy is the major cause of nephrotic syndrome in children, but it still occurs in adults. Around 10 to 15% of cases with the primary nephrotic syndrome have minimal change nephropathy or disease. And this is, of course, as you all know, that when you do a biopsy and you look at it in light microscopy, you don't see anything really, the minimal change, whereas on electron microscopy, you will see this food process effacement. So the guidelines from 2012 was that recommend corticosteroids for initial treatment, and also given a single daily dose of 1 milligram per kilogram with a very high maximum 120 milligrams. And this should be maintained for 4 weeks, and for a maximum if complete remission achieved, and for a maximum period of 16 weeks if complete remission is not achieved. And then you should continue with slow taper. And also there is this provision for patients who have relative contraindication or intolerance, that you could use oral cyclophosphamide or calcineurin inhibitors. And also there is this provision for frequently relapsing minimal change disease, which is also oral cyclophosphamide or CNIs, and also the same for infrequent relapses. Now in the 2020 guidelines, then there are the practice points for the diagnosis, that minimal change disease can only be diagnosed with kidney biopsy, which is the same as before. And then for the prognosis is that the long-term kidney survival is excellent in minimal change disease in patients who respond to corticosteroids, but less certain for patients who do not respond. And my comment here is that if you don't get a response, you should repeat the biopsy, and there may be a focal segmental glomerulosclerosis that you missed on the first biopsy. So the initial treatment is the same as before, recommending a high-dose oral corticosteroids for initial treatment of minimal change disease. And keeping in mind that children usually are really fast responders, whereas adults can take longer to remit on steroids, as shown here in a paper from Clinical JSON a few years ago. So the initial treatment, and it's basically the same, that the high-dose corticosteroid treatment should be given for no longer than 16 weeks, and you should begin tapering 2 weeks after remission. And then this is saying that usually you use daily oral corticosteroids, which is most often, and the route and frequency of administration can be individualized to patient needs. For instance, every second day, or I had a patient who refused to take oral corticosteroids, so we had to give her IV every week or something like that, and that also worked. For patients in whom corticosteroids may be contraindicated as before, like high risk of diabetes or psychotic episodes, you can consider initial therapy with cyclophosphamide, CNI, or mycophenolic acid analogs. And the evidence for MMF is not that strong, But here is some more recent data on tacrolimus monotherapy, and this is a randomized controlled trial giving 25 patients tacrolimus and the other 25 prednisolone. And here you can see that the remission rate was the same at 26 weeks, although the patients who were given tacrolimus had a slower response, but eventually they all went into remission basically, and the relapse rate was quite similar. And just today I saw this new study from Jason that was published, I think, today, combining low-dose corticosteroid and tacrolimus for remission induction in minimal change disease. And this was interesting. They used a low dose, which is 0.5 milligram per kilogram, plus tacrolimus, 0.05 milligram per kilo twice daily, and then high dose there 1 milligram per kilogram per day in the other group. And what is shown here, that the complete remission at 8 weeks was similar in the both groups, but the relapse rate was much smaller in the tacrolimus low dose steroid group. So that could also be an option, I suppose, if you have a patient who you want to not give them all this steroid dose, or if you have a patient who relapses and you want to give them lower steroid doses, as it has more toxicity long term. This is another study just showing rituximab as frontline therapy. So this is again without steroids, and these patients, which is a case series, responded, and most of them were in remission at 6 months and also at 9 months. So just talking about these targeted therapeutics in these diseases. Of course, there is an immunological aspect of rituximab, but it has also been hypothesized that there may be a non-immunological effect. So, for instance, cyclosporin and rituximab, they actually stabilize the podocyte. Cyclosporin protects synaptopodium from cathepsin-mediated cleavage, whereas rituximab preserves sphingomyelin phosphodiesterase acid like 3B, SMPDL3B expression. So there may be some other action of mechanism and action that is useful with these therapeutics. So continuing with the 2020 guidelines, the treatment of infrequently relapsing minimal change disease. Here they suggest that you could administer again oral prednisone at a daily dose of 1 milligram per kilogram, a maximum dose of 80 milligrams per day for 4 weeks, or until remission is achieved, and then tapering it to try to discontinue it in a sort of shorter period of time than 6 months. But I think my comment here is that you have to consider the cumulative corticosteroid dose and adverse events. You may not want to repeat these high doses of prednisolone, and there may be other options. So I want to present a case. This is a woman born in 1955. She has a nephrotic syndrome diagnosed in 1993, and she was actually the first patient I met on my first day as when I started in nephrology. So she had a diagnosis of minimal change disease on the biopsy, and she was treated with high dose corticosteroid. She went in remission, but she was a frequent relapser, and corticosteroids were repeated. And then after a while, we couldn't stop with the steroids, and she became steroid dependent. Eventually, she was given cyclophosphamide, and she went again into remission. All this time, the renal function was normal, which is typical of a minimal change disease most of the time. But she was still steroid dependent, and after this, with a lot of steroid, the cyclophosphamide, the adverse events started accumulating. She had an early menopause, osteoporotic fractures, and she had a depression. So I had read this paper in 2007, a French paper with a 23-year-old woman that had 30 relapses of minimal change since she was 6 years, and she was treated with rituximab, and she went into remission and stayed in remission for 28 weeks. So I decided to give my patient rituximab in January 2009, and she went into complete remission, and corticosteroids were tapered after 6 months, and she hadn't been on steroids, I mean, basically for many years until that point. She had a relapse after 3 years and was treated again with rituximab, and she had a complete remission, and we continued with low dose corticosteroids for a couple of years, but eventually tapered it, and she hasn't had any relapse in 2012. And this is, I just put this, I published this in 2014, our case series of multi-relapsing steroid-dependent and resistant minimal change disease. And we gave the patients rituximab in various doses, which is also a problem because in all these case series, the doses are not the same, but we managed to get 13 patients in complete remission, 2 in partial remission with a big reduction of proteinuria, and 1 patient didn't respond. And one of these partial remission patients was actually treated again with rituximab and went into complete remission. And we managed to taper the corticosteroid dose in many patients. And I also have follow-up data a few years ago that we had relapses in 7 patients, and they were treated in rituximab again in 4 patients. And of this series of these 16 patients, in follow-up in 2015, 5 patients never relapsed, and this included a 95-year-old woman. So this is the recommendation from the 2020 guidelines. They recommend cyclophosphamide, rituximab, calcineurin inhibitors, or MMF for the treatment of frequently relapsing corticosteroid-dependent minimal change as compared to prednisone alone or no treatment. So there are several case series that are published. There are no, however, with very high remission rates, and most likely they can come off other immunosuppressant therapy. But there is no randomized controlled trial published in adults as of yet. And I think that that is one of the problems why it's not first chosen as first therapy here. It's a suggestion. And I think also it's important to choose therapies, when you choose therapy for relapsing steroid-dependent minimal change, you have to consider the age of the patient, fertility, renal toxicity, and other adverse events. In a young person, you may not want to use a lot of cyclophosphamide for obvious reasons. So focus augmented glomerulosclerosis is a disease of glomerular injury that is directed at the podocyte, and you have these sclerosis in parts, segmental of some focal glomeruli by light microscopy. And this is, if it's untreated, progressive disease, and some patients may also relapse after kidney transplantation. So these are the primary FSGS that we are interested in this talk, where we believe that there may be a circulating permeability factor, and then there is a secondary FSGS that we don't treat with immunosuppression, and familial genetic FSGS that I will not mention that much, but I will just say one word about COVID-19 that may be a contributing factor to some cases of FSGS that have been seen now, and it seems to be associated with the APOL1 risk allele. So it's important to differentiate between primary and secondary FSGS. You have this lesion on kidney biopsy, you have a nephrotic patient, and then you can say that it's likely that you have a primary FSGS. Oh, sorry, and then and you should treat with immunosuppression. If you don't have a response, you can consider genetic therapy. But in the absence of nephrotic syndrome, you may evaluate the patient for underlying cause to exclude secondary FSGS, and also consider genetic screening. You should not start immunosuppression, rather go for supportive therapy, and then monitor proteinuria and serum albumin. If the patient has worsening proteinuria reduction in serum albumin, because they're developing their primary FSGS perhaps, then you go back here and consider that it may be a primary disease. Genetic testing is a practice point that it may be beneficial for selected patients who should be referred to specialized centers with such expertise. And it's more likely that with children have FSGS that it is of a genetic cause, but it may happen later also. And again, immunosuppression should not be used in adults with FSGS of undetermined cause or in those with secondary FSGS. It's important to remember. So the initial treatment, again, is high-dose oral corticosteroids to be used as first-line immunosuppressive therapy, used for immunosuppressive treatment for primary FSGS. And it should be continued until complete remission achieved or as tolerated by patient up to a maximum of 16 weeks, whichever is earlier. And this is based on a study by Cado Ponticelli, where they actually showed that the complete remission rate was much higher if the patients actually continued with this high-dose steroids for if 16 weeks went on for longer, as compared to 15% if you had shorter treatment. And people tend to forget this, that actually it can be very useful in this diagnosis. So, and if they respond to this treatment, they should receive corticosteroid for at least 6 months. And if there is a relative contraindication or intolerance, the alternate suggestion is calcineurin inhibitors as initial therapy. And if and that should also be given at least for 6 months, rather than continuing with corticosteroid monotherapy if they are resistant to corticosteroids up front. So the duration of therapy is here suggested to be at least for a minimum of 12 months with CNIs to minimize the risk of relapse. And if they are resistant to or intolerant to both corticosteroids and CNIs, they should be referred to specialized center for consideration of rebiopsy, alternative treatment, and discussion if there are other options. So what about rituximab in FSGS? It's a bit problematic because rituximab can be effective in some cases and some populations, but the results are very discordant. And it also seems that you should have at least some kind of response to other immunosuppressive treatments to be of importance. So if you're completely resistant to all other drugs, the likelihood that you will respond to rituximab is not that high, even though people still use it or try to use it. So, and then there's also this question, is there an immunologic effect, or is it just that we protect the foot processes or the by this non-surgical method? That is not completely clear. There are ongoing randomized controlled trials in adults, both for FSGS and minimal change disease, and we will see what happens in the future if we can find more predictive factor who will respond to rituximab. But we need more research of the underlying causes and disease mechanism. So this is just about the future. This is actually a study that already has happened. One of my co-speakers was part of this. It's the sparsentan in patients with primary FSGS. It was a randomized active control phase 2 trial. Sparsentan is a dual endothelin type A and angiotensin II type receptor antagonist. And this was compared with irbesartan, angiotensin II receptor antagonist. And one arm received irbesartan and the other arm received irbesartan and sparsentan. And it was shown that patients with FSGS achieved significantly greater reductions in proteinuria with 8 weeks of sparsentan versus irbesartan alone. And it was safe and well tolerated. So now there is an ongoing phase 3 trial that is called the duplex trial. In 300 patients, this was 109 patients in the phase 2 trial, and the treatment is for 108 weeks, and the end of screening was last week, and we will have the results in 2 years if this is improvement or a new therapy for primary FSGS patients. So the conclusion is that the main changes between 2012 and 2020 guidelines is that tacrolimus and rituximab has been suggested to be of potential use also in initial therapy for minimum change disease. There is also more variety suggestion for relapsing disease, which is then, I believe, include or perhaps be stronger towards rituximab. For FSGS, it is important to define who should be treated with immunosuppressive therapy and where supportive therapy is more adequate. Genetic testing in select cases may be important, and the role of rituximab is still unclear in FSGS. But for FSGS, we are anticipating results from ongoing clinical studies within a few years. And then I just want to mention that considering the results from the DAPA CKD trial, you may wonder if SGLT2 inhibition has a role in glomerulitis with proteinuria, and from the DAPA-CKD there was positive data in IgA nephropathy patients, and perhaps this will be applicable in FSGS patients who are resistant to other treatment in the future. So that is what I have to say, and we will finish my talk, and I'm looking forward to questions later.
Thank you, Annette. We will take the questions. You have already received some questions, but I will be forwarding them at the end. Now I will move forward to Dr. Eleni Frangou from Limassol General Hospital, Cyprus, and she will give us the latest information about lupus nephritis. Please go ahead.
Hello from me. So thank you for the invitation. The incidence of nephritis in patients with lupus is 20 to 60%, and kidney involvement in lupus patients has been associated with higher mortality, mainly when it progresses to kidney failure. Therefore, the goal of treating lupus nephritis is to preserve kidney function and reduce morbidity and mortality while minimizing medication-associated toxicity. Patients with SLE should be actively and regularly monitored, since they may remain clinically silent for a significant period of time. Testing is indicated at lupus presentation and at suspicion of a flare, and should include serum creatinine, urinalysis, both dipstick and sediment, and a spot urine protein to creatinine ratio. If there is evidence of abnormal proteinuria or sediment, then proteinuria should be quantified, and if it exceeds 500 milligrams per day, then a kidney biopsy should be considered. Now, if there is confirmed decreased or decreasing GFR attributable to lupus and not to other causes, then a kidney biopsy should be again considered, and this should be read by an experienced kidney pathologist and classified according to the revised ISN RPS classification system that now includes activity score, chronicity scores, and other items that were not included in these scores. Now, this algorithm is a new practice point. Let's have a look at treatment. 2020 KDIGO guidelines recommend that patients with lupus nephritis should be treated with hydroxychloroquine or an equivalent antimalarial unless contraindicated. Now, this recommendation has been upgraded to level 1C. This recommendation places a high value on data demonstrating various benefits associated with hydroxychloroquine use, including reduced risk of disease flare, reduced risk of progressive kidney damage, and vascular complications. It also places a high value on data demonstrating the favorable safety profile of hydroxychloroquine, since significant side effects are uncommon. These are retinopathy and cardiotoxicity, and are mainly observed after prolonged and high-dose use. A new practice point is that adjunctive therapies may be considered for all patients, and these include measures to reduce cardiovascular risk, proteinuria, infection risk, bone injury, UV exposure, premature infertility, and also highlight the necessity for planning in pregnancy and cancer screening. Patients with class 1 or class 2 lupus nephritis usually have low-level proteinuria, normal renal function, and sometimes microscopic hematuria. And immunosuppressive treatment in these patients is guided by extrarenal manifestations. Patients with class 1 or class 2 nephritis with nephrotic range proteinuria or nephrotic syndrome are considered to have lupus podocytopathy and are treated as minimal change disease. Initial steroid monotherapy may achieve remission in 90% of patients within 4 weeks. Data on relapse are limited, and optimal duration of therapy is not known. Patients with a history of relapse should be maintained in a combination therapy of low-dose steroids plus another immunosuppressive agent. Now this has been changed from a recommendation level 2D to a practice point. Let's have a look at initial therapy in patients with class 3 or class 4. These guidelines recommend that patients with active class 3 or 4 lupus nephritis, with or without a membranous component, be treated initially with steroids, plus either low-dose cyclophosphamide or mycophenolic acid analogs. The dose of intravenous cyclophosphamide was not included in the previous recommendation, and it only stated IV cyclophosphamide or mycophenolic acid analogs. This recommendation places a high value on data demonstrating that combination therapy of steroids with either cyclophosphamide or MMF induce better results in renal response in patients. This recommendation also places a high value on data demonstrating that MMF and IV cyclophosphamide have equal efficacy, and place a relatively lower value on data examining multi-target therapy in comparison to IV cyclophosphamide, since these data were obtained in the short term, we're examining the short term, and were mainly conducted in races of Asian origin. All current regimens of lupus nephritis include steroids, corticosteroids. However, now lower doses of methylprednisolone pulses are given, up to 0.5 grams per day for up to 3 consecutive days. Prednisone starting dose is also lower, 0.6 to 1 milligram per kilogram, going down to 20 milligram per day. And tapering is also faster, so as by week 12, most patients receive a dose of less than 7.5 milligrams. In general, dose, tapering regimen, and duration are opinion-based. The next practice point is that intravenous cyclophosphamide should be used in patients who may have difficulty adhering to an oral regimen. Cyclophosphamide may be given either orally or intravenously in a standard dose, also known as the NIH regimen, or in the low dose, also known as the Eurolupus regimen. The NIH regimen is cyclophosphamide up to 1 gram per square meter monthly for 6 months, whereas the Eurolupus regimen is a fixed dose of 500 milligrams every 2 weeks for 3 months. The choice can be individualized. Oral cyclophosphamide and standard dose NIH regimen have comparable efficacy, and they have been studied in different races and for all levels of disease severity. The Eurolupus regimen, the low dose, is comparable to the standard dose. However, this has been studied in Caucasian white patients, and although now we have some data emerging from other races and ethnicities, standard dose is less toxic than oral cyclophosphamide. However, low dose has the most favorable immediate toxicity profile, as evidenced by less infections. A mycophenolate-based regimen should be used for patients at high risk of infertility, patients who have moderate or high prior cyclophosphamide exposure, and patients of Asian, Hispanic, or African ancestry, as evidenced by the superior efficacy that MMF has when compared to IV-Cyc in these populations. Side effects are quite similar. They have a different profile. Triple immunosuppressive regimen that includes a calcineurin inhibitor, low-dose MMF, and steroids should be given in patients who cannot tolerate standard dose mycophenolic acid analogs or will not use cyclophosphamide-based regimens. This was based on data demonstrating that superior efficacy of the triple therapy was only observed in the short term and not in the long term, only in Asian population. Voclosporin is a novel calcineurin inhibitor that is promising, and when added to standard of care therapy, it has superior efficacy when compared to placebo. However, side effects were more common, and currently we're waiting for the results of a phase 3 study to be published. Azathioprine or leflunomide may be considered in patient intolerance, lack of availability, and or excessive cost of standard drugs, since azathioprine has comparable efficacy in achieving complete response or partial renal response at the short term. However, side effects were more common, and chronicity index after 2 years of treatment was more. While not yet ready to be recommended as first line, biologics may be considered for individual patients, such as non-responders or patients who do not tolerate standard therapy, or they may be used as steroid-sparing agents. Although most phase 2 and 3 clinical trials have failed to demonstrate short-term efficacy of biologics, we now have the results of a recent trial published some days ago in the New England Journal of Medicine that demonstrated that more patients who received belimumab had a primary efficacy renal response, and these patients had a lower risk of event or death. So we're waiting results from ongoing trials to finally decide what we will do in the future with biologics. Let's have a look at maintenance therapy in class 3 or class 4 nephritis. These guidelines recommend that after completion of initial therapy, patients should be placed on mycophenolic acid analogs for maintenance. Now, azathioprine is not included in this recommendation. This recommendation places a high value on data demonstrating that mycophenolate mofetil is not only associated with less adverse events, but also with superior renal and patient outcomes when compared to IV cyclophosphamide. It also places a high value on data demonstrating that low-dose long-term MMF is associated with reduced risk of renal relapses when compared to azathioprine. And it places, again, a lower value on data examining multi-target therapy in comparison to azathioprine, since the follow-up was relatively short. After completion of initial therapy, patients should be placed on mycophenolic acid for maintenance. In the early maintenance phase, mycophenolic acid should be our first choice. MMF up to 2 grams per day or equivalent dose of mycophenolic acid. Azathioprine is an alternative to mycophenolate in patients who do not tolerate or do not have access to mycophenolate, or in patients who consider pregnancy, and the dose is up to 2 milligrams per kilogram per day. If these two cannot be used for maintenance, then calcineurin inhibitors, either tacrolimus or cyclosporin or mesoribin, should be considered. Tacrolimus at about a trough level of 5. Steroids should be tapered to the lowest possible dose, not exceeding 7.5 milligrams per day, except when they are required for extrarenal lupus manifestations. Steroid avoidance has been attempted by the addition of rituximab to MMF. It had good results. However, it has been attempted only once. Discontinuation of steroids should be considered after patients have maintained a complete clinical kidney response for approximately a year. Optimal duration of maintenance therapy is not known. Therefore, total duration, initial plus maintenance therapy, should not be less than 36 months in patients with a complete renal response and without ongoing extrarenal manifestations. And this was based on the fact that despite 36 months of treatment, a high incidence of treatment failure and kidney flares was observed. It was also based on data demonstrating that despite 36 months of immunosuppression and despite 12 months of complete remission, up to half of patients showed inflammatory histologic activity on repeat renal biopsy, whereas patients with a partial remission that remained on therapy finally demonstrated resolution of histologic activity after about 10 years. Data on pure membranous class 5 nephritis are very few. There are a few randomized controlled trials with a very small number of participants. Therefore, data are obtained from observational studies and pooled analysis. In addition to monitoring the level of proteinuria by RAS inhibition and blood pressure control, and in addition to treating complications such as thrombosis, dyslipidemia, and edema, patients with nephrotic range proteinuria should be treated with a combined immunosuppressive treatment with steroids plus another agent. MMF is a reasonable first choice. If it is ineffective, to induce long-term remission, cyclophosphamide may be given, but not more than 6 months. And in patients reluctant to take cyclophosphamide, calcineurin inhibitors or rituximab may be tried. In all patients, either with low-level proteinuria or nephrotic syndrome, hydroxychloroquine is essential. Response is associated with a long-term favorable outcome, favorable renal outcome. And although there are no universally accepted criteria for the level of improvement required, all response criteria require reduction in proteinuria to either less than 0.5 to achieve a complete response, or by at least 50% and less than 3 to achieve a partial response. And at the same time, they require stabilization or improvement in kidney function within 6 to 12 months of starting therapy. If patients are improving, allowing 18 to 24 months to achieve a complete response is a reasonable option. Now, time is added in these recommendations, and in these guidelines, there is a more strict stabilization of creatinine from baseline. Patients whose response is unsatisfactory are patients with no improvement despite treatment for 3 to 4 weeks, or patients whose improvement is suboptimal after 3 to 4 months of treatment. And in these patients, adherence to treatment should be verified, adequate dosing of medication should be ensured, and if there is concern for chronicity or other diagnosis such as TMA, a kidney biopsy should be repeated. If there is persistent disease activity, then we may switch to an alternative first-line regimen. And if the patient remains refractory to first-line treatment, then combination therapy, a triple combination therapy may be considered, or we may consider adding rituximab or extend the course of IV cyclophosphamide pulses. And this is a new practice point. There are no data on treating lupus nephritis relapses. However, these guidelines recommend that relapses should be treated with the same initial therapy that achieved original response or an alternative recommended first-line therapy. They also mentioned that renal flares may be preventable, as evidenced by preemptive treatment in patients with increasing anti-dsDNA titer or consumed complement levels. Patients with lupus nephritis and thrombotic microangiopathy should be managed according to the underlying etiology of thrombotic microangiopathy. ADAMTS13 activity, antibodies against ADAMTS13 and antiphospholipid beta antibodies should be tested. And if these are not available, or if a lot of time is needed for their results, then the plasmic score will discriminate patients at moderate and high risk of having TTP. In these patients, plasma exchange should be immediately started, as well as steroids while awaiting for the results of our previous tests. If ADAMTS13 activity comes low, then we are talking about lupus-associated TTP, thrombotic thrombocytopenic purpura, and these patients are treated with plasma exchange plus steroids plus rituximab, and perhaps caplagizumab, that is a von Willebrand factor inhibitor. If ADAMTS13 activity is normal and antibodies, antiphospholipid antibodies are positive, then we are talking about antiphospholipid syndrome nephropathy, and patients are treated with anticoagulation with warfarin and perhaps plasma exchange. In patients with normal ADAMTS activity and negative antiphospholipid antibodies, we have to examine for the presence of complement-mediated thrombotic and microangiopathy or other etiologies, and these patients may be treated with eculizumab. In these guidelines, all this is a new algorithm, and novel therapies are now suggested. Patients with active lupus nephritis should be counseled to avoid pregnancy while the disease is active or when they are taking teratogenic drugs for at least 6 months after lupus nephritis becomes inactive. Hydroxychloroquine should be continued during pregnancy, and low-dose aspirin should be started before 16th week of gestation, and steroids, hydroxychloroquine, azathioprine, and calcineurin inhibitors are safe in pregnancy. Unfortunately, information in childhood onset lupus is limited, and these guidelines suggest that similar regimens used in adults may be used in pediatric lupus nephritis patients, but we have to consider several issues such as dose adjustment, growth, fertility, social aspects, and psychological aspects. And finally, lupus nephritis patients who develop kidney failure may be treated with hemodialysis, peritoneal dialysis, or kidney transplantation. Transplantation is the preferred renal replacement therapy since it is associated with reduced mortality. And we have to keep in mind that although lupus nephritis can recur to the graft, graft loss is rare, and this is a new practice point. Therefore, my conclusions, unfortunately, not so many things have changed since 2012. And some research recommendations could be that apart from clinical trials, better understanding of the pathogenesis of lupus nephritis is essential. And apart from histological classification of patients with lupus nephritis, molecular classification and additional phenotyping focused on mechanisms of tissue injury are also necessary to identify novel agents to be used for precise and personalized therapy in lupus nephritis. Thank you, and I would be happy to answer your questions.
And I will speak only very shortly about anti-GBM disease because there is not so much new. I will deliberately omit these studies which are not the part of I'm sorry, I have some problems with my slides. Which are not a part of the guidelines. So I will not speak about IgG endopeptidase in anti-GBM disease, and will not speak also about complement inhibition in ANCA vasculitis. This is, by the way, the part of the Medscape program which we prepared with David Jane. So concerning anti-GBM disease, what is stressed in the new guidelines, it was also the present of 2012 guidelines that the diagnosis should be made very urgently, and those patients who are diagnosed, almost all of them, should be treated with immunosuppression, which should be started immediately and should contain cyclophosphamide and corticosteroids, and those patients should be treated also with plasma exchange. And there are only some exceptions. We should not treat the patients who are already dialysis dependent at presentation and who have 100% of crescents in adequate biopsy sample and do not have pulmonary hemorrhage. Here you see the algorithm. So in the beginning, we have rapidly progressive glomerulonephritis from renal biopsy, usually with the deposition, linear deposition of anti-GBM antibodies. Then we should look for the presence or absence of alveolar hemorrhage, anti-GBM antibodies in circulation. And we should not wait for the data. We are not back within 24 hours. We can rely only on high suspicion and start treatment. Of course, when the data are available very soon, we should we will be much more happy, and we will start treatment already stressed with corticosteroids, cyclophosphamide, and plasma exchange. And there are some details concerning the use of plasma exchange. It should be performed until GBM titers are no longer detectable. Cyclophosphamide should be used for at least 2 to 3 months. And there is no maintenance treatment for anti-GBM disease recommended because the rate of relapse is very low. And the exception, of course, is the concomitant positivity of anti-GBM and ANCA, because in that case, the patient should be treated with maintenance therapy in a similar way as a patient with AAV. And there is some small place for Rituximab, which can be tried in a refractory anti-GBM disease, but the experience is very limited based on only case series and no randomized control trial. And what is important, kidney transplantation is indicated only in patients who are anti-GBM undetectable for at least 6 months. And I will now speak mostly about ANCA-associated vasculitis, which is the area of kidney disease where we have probably the highest number of randomized control trials. You see that there were many trials available already in 2012. When the first guidelines were published, and there were some new trials which appeared since 2012 until 2020, and I will speak only about some of them because we have not time enough to do so in detail. I will speak about initial therapy and relapse, and about the role of plasma exchange, and then about the maintenance therapy in ANCA-associated vasculitis. So starting with initial therapy and relapse, I would like to remind you that the outcome of untreated patients with ANCA-associated vasculitis really was very poor, and median survival was something like 5 months, with 1 year mortality in about 82%. So with the introduction of cyclophosphamide, everything dramatically improved. But it was quite early within the 1990s and early years of this millennium, clear that the treatment is very effective. The patients are no longer dying because of active vasculitis. It's less than 20%, but they are dying because of infections. And then also during the second and for the third years of the treatment, because of infection, cardiovascular disease, and malignancies. So it means because of complications which are in some way related to the toxicity of treatment. So originally the idea was that we should avoid this toxicity with decreasing the cumulative dose of cyclophosphamide, either with early switch from oral cyclophosphamide to azathioprine, or with using intravenous pulses of cyclophosphamide instead of oral continuous cyclophosphamide, because this is associated with about 50% decrease of the cumulative dose of cyclophosphamide. But unfortunately, in both of these trials, in Cycazarem, you see that there was a trend to higher relapse rate in patients switched to azathioprine early, and in Cyclops, there was a lower number of patients who were free of relapses in the limb with cyclophosphamide. But it means that this is not the best way how to avoid relapses and to improve the outcome of the patient. And here you also see that a low cumulative dose of cyclophosphamide was the predictor of relapses. The analysis published about 10 years ago. So we needed something new, and this new drug which could substantially improve the outcome of patients was Rituximab, which was originally tested in almost 200 patients with generalized ANCA-associated vasculitis in the RAVE trial. But you should see that these patients had very good, very normal GFR, which is uncommon in patients we see as nephrologists. And these patients were randomized either to conventional treatment or to Rituximab for remission induction, and the main endpoint was disease activity at 6 months. And here you see that in new patients, rituximab was similarly effective as cyclophosphamide, but it was better in patients with relapses of the disease, 67% versus 42%. And there was no difference, and this is important, in the rate of adverse events between both limbs. We had the chance to take part in a much smaller study in only 44 patients called Rituxvas, but the study was very important because those patients who were randomized to the study were patients with much lower glomerular filtration rate, about 20, and some of them required dialysis when recruited for the trial. And in this study, conventional treatment with cyclophosphamide was compared with rituximab with only 2 introductory cyclophosphamide pulses, and you can see here that the treatment was similarly effective in terms of sustained remission and increase of GFR at 12 months. So this was the basis for the recommendation for 2012. The recommendation was that cyclophosphamide and corticosteroids should be used as initial treatment, and rituximab was recommended even in patients with relapses only as an alternative, and it was not recommended in patients with severe disease because the experience was limited. And you see here that the recommendation for relapses was similar as for the initial treatment. Since then, new data on rituximab were published. Sub-analysis from a RAVE study showed that rituximab is quite effective even also in patients with renal involvement, and long-term data from Rituxvas trial show that there is a similar long-term survival and relapse-free survival in patients originally treated with cyclophosphamide and rituximab. And what was also important, it was shown that PR3 positive patients who are much more prone to relapses benefited very much from rituximab treatment, because at 6 months, 12 months, and 18 months, those who were anti-PR3 positive and had relapsing disease without any maintenance treatment still had a much higher chance to remain in remission. And very recently, the first data from Ritazarem study were published, and this study randomized patients with a relapse of ANCA-associated vasculitis the maintenance with either rituximab or azathioprine, but all the patients were treated with remission induction with rituximab. And here you see rituximab was very effective as induction treatment, because more than 90% of patients achieved remission within 4 months, and substantial part of them became ANCA negative. And what is also important is that we now have data showing that compared to cyclophosphamide, which apparently increased several times the risk of malignancies, all sides, bladder, and also skin and malignancies and leukemias, rituximab does not increase the risk of malignancy. So in that way, it is much safer. But what is important is that in rituximab, in Rituxvas trial, and was similar in RAVE, there was a similar incidence of severe adverse events, namely infections. And this is probably because of high dose corticosteroids being used in both limbs. So I will return to that. And now I will only mention what was already said by Annette Bruchfeld, that in new guidelines 2020, there is a different approach. We have no recommendation and suggestion, but we have recommendation and practice points. Practice points are used where there is insufficient evidence, and recommendation where there is evidence available. Now we can tell something about the recommendation from 2020. You see that first practice point is related to the diagnosis, and what is stressed is that waiting for a kidney biopsy to be performed or reported should not delay starting immunosuppressive therapy, especially in patients with severe cause of the disease. So it means that in those patients with rapidly deteriorating kidney function, and also in patients with alveolar hemorrhage. So some of these patients may not necessarily be biopsied, or the biopsy may be postponed, but the treatment must start very early. And here is an algorithm treatment. You see that in this algorithm, rituximab, both in induction and maintenance treatments, is on the same level. I will return to that later on. And compared to what was recommended concerning the initial treatment in 2012 is quite different in 2020. Because here it's stated that we recommend corticosteroids in combination with either cyclophosphamide or rituximab. So rituximab is now on the same level as cyclophosphamide and can be used as a first-line treatment in new setting. We should prefer cyclophosphamide, and you see that rituximab should be preferred in children and adolescents because of gonadotoxicity. The same in premenopausal women and men concerned about their fertility, but also in frail older adults and in some other people, such as anti-PR3 positive patients. So much remain for cyclophosphamide. So the major reason for the use of cyclophosphamide is difficult access to rituximab, which unfortunately still is the case in many countries. And the second, which I already mentioned, advanced kidney disease because of the lack of evidence. And here is also a consideration if we could prefer intravenous or cyclophosphamide. And I think that in most European centers, we prefer intravenous cyclophosphamide. And once again, oral cyclophosphamide may remain as an alternative where there is a still importance of cost, and where there is an access to infusion center difficult. So it means, for instance, in large countries such as Canada or Australia, but probably not in many European countries. What I already mentioned was that the risk of adverse events remained the same in patients treated with rituximab and with cyclophosphamide. This is probably because of high doses of corticosteroids being used in both settings. And here we see that in Pexiva's trial, there was compared the traditional regimen of relatively high dose corticosteroids with rapid tapering to much lower doses. And what is important is that in terms of efficacy, it was similarly effective, and there was a lower risk of serious adverse events with low dose of corticosteroids. So it means that in these recommendations, 2020 recommendation, there is a practice point which clearly recommends to use this rapid tapering of corticosteroids in most patients. And we have here also this point which is related to relapsing disease. You see that in 2012, both treatments were on the same level, and now in patients with relapsing disease, there is a statement that we should preferably use rituximab because it is probably more effective. And still, there is no great progress in refractory disease because it is suggested that these patients should be treated with the opposite treatment which was used in the first time, and then we can use anything which can be available, such as, for instance, high dose IgG or plasma exchange. And now, what is the place of plasma exchange in the treatment of ANCA-associated vasculitis? There was a large randomized control trial called MIPEX, published more than 10 years ago, which showed that it is better for the patients in terms of real outcome to be treated with plasma exchange than compared to pulses of methylprednisolone based on the background of cyclophosphamide and corticosteroids. And then it was confirmed in meta-analysis that this treatment has no impact on mortality, but there is an impact on the preservation of renal function, at least at 3 months and 1 year. There was a decrease of the rate of ESRD by about 36%. And so this was the background for the recommendation from 2012 that plasma exchange should be used in patients with dialysis or with rapidly increasing serum creatinine, and also in patients with pulmonary hemorrhage and the concomitant positivity and of anti-GBM. But since then, There was some negative data. Long-term follow-up of MIPEX showed there was no difference in proportion of patients free of ESRD or deaths. And also here you see that reduction of the risk of ESRD did not reach statistical significance during long-term follow-up. And there we expected that we will get the final response to the question if plasma exchange is or is not effective from the large trial called PEXIVAS, which was published this spring, which was by far the largest trial in ANCA-associated vasculitis, recruiting more than 700 patients with serum creatinine more than 200 micromoles per liter, and these patients were randomized to the same background treatment and either no plasma exchange or plasma exchange as add-on treatment and followed for 2 years. And here you see that the mean creatinine was about 300. There were almost 20% of patients who were undergoing dialysis, and there were altogether about 26% of patients with alveolar hemorrhage. So of course, most patients had kidney involvement, and almost 50% had involvement of the lungs, and still most patients were treated with cyclophosphamide, about 50%, although it was also allowed to use rituximab, but this was used only in 15% of patients. And here are the results. There was no significant effect of plasma exchange on primary endpoint of death or end-stage renal disease, and this was not present. This effect was not present in any of the subgroups. But it seems that these data still need some further analysis because what is important is not the combination of DES and ESRD, but ESRD itself. And it seems that the effect of plasma exchange may be temporary, which is still important for the patients. So taking into consideration this field still is open to some further studies and analysis. It is now said that we should only consider plasma exchange for patients requiring dialysis with rapidly increasing serum creatinine and in patients with diffuse alveolar hemorrhage, but still plasma exchange should be used in patients with a combination of ANCA and anti-GBM. Finally, something on the maintenance therapy. So what was stated in 2012 was that the maintenance therapy should be used in all patients and should be used for at least 18 months. And what was recommended was either azathioprine or mycophenolate or methotrexate in patients with well-preserved renal function. Since then, we once again have some new data. First were the data from the REMAIN trial, which compared 2 lengths of treatment, maintenance for 24 months up to, or continuation of the maintenance until up to 48 months, and it was shown that it was much better in terms of prevention of relapses when the maintenance treatment was prolonged. You see that it was also important in the terms of major relapse rate, and what is also important is prolonged maintenance treatment was not associated with higher toxicity. So it is generally recommended that at least some patients should be treated with prolonged maintenance, probably namely those patients who are anti-PR3 positive or who remain ANCA positive during the long-term follow-up. And once again, there seems to be a very important role for rituximab in the maintenance treatment. First study which showed the efficacy of rituximab in the maintenance treatment was MAINRITZAN trial. Once again, the trial was done in patients with relatively well-preserved renal function with a mean GFR of about 60. But once again, you see that it showed there was a major difference in terms of relapses and major relapses among rituximab-treated patients. They were much better with only 5% of major relapses compared to azathioprine-treated patients with 29% of relapses. And there was a similar rate of adverse events. And what is even more important, than during the long-term follow-up of 5 years, there was not only preserved the efficacy of rituximab in prevention major and minor relapses, there was also lower mortality in patients originally treated with rituximab. There was better overall survival. And we have now some data also from Rituximab trial, not yet published. And you see that comparing maintenance treatment with azathioprine and rituximab in all patients primarily treated with rituximab. Rituximab was definitely better. Now there is an ongoing trial, MAINRICH-3, which should decide what is the optimal length of the rituximab treatment, comparing short-term with long-term rituximab treatment. And here you see the final slides that we recommend maintenance treatment with either azathioprine or rituximab. And generally following cyclophosphamide, you can use either azathioprine or rituximab, and following rituximab induction, rituximab maintenance is preferred. It's clear that the duration should be at least 18 months, but can be longer in some patients. And in fact, the optimal duration, especially of rituximab maintenance, is currently unknown. Once again, you'll see that there is a consideration which patients should be treated in maintenance with rituximab and which with azathioprine, and there is not so much remaining for azathioprine. We should prefer azathioprine in patients with low baseline IgG with the history of hepatitis B exposure, and especially with in patients in countries with limited availability of rituximab. So I'm coming to the conclusion. So there is a tremendous success of rituximab in ANCA-associated vasculitis, which becomes the treatment of choice in patients with major relapses, and maybe used also in new patients, and is probably the best maintenance treatment. What is currently not completely clear is the role of plasma exchange, and it needs to be further elucidated based on the ongoing sub-analysis and meta-analysis. And I did not speak about it, but we have now good chance to have another treatment which could replace corticosteroids. This is avacopan, and this is the part of the Medscape program I already mentioned. So thank you for your attention.
Thank you very much, Vladimir, for the thorough talk. Now, could I please have all my speakers on the screen, and I'm gonna forward you some of the questions that I have received. I want to start with Annette. Couple of questions regarding minimal change disease, and they are asking about our followers. Would you recommend MMF in minimal change disease? And the other question about minimal change disease is, when would you recommend the anticoagulants for the treatment of that patient?
All right. So I usually, I mean, it's also a question of where you are in the world. If you can't afford rituximab and things like that, but MMF for me is sort of last line therapy. So I would prefer for relapsing, frequent relapser, I would prefer rituximab, followed by perhaps I don't know, cyclophosphamide, but this is a general young population, so I'm sort of skeptic. For cyclophosphamide, skeptic for younger fertile patients in general. And then you have, of course, CNIs. And MMF, I think, is really less well studied. As for anticoagulants, that's an interesting question. The idea, if you can get the patient into remission quickly, then that would be a shorter period of time, and then you would use low molecular weight heparin, but if it goes on for longer, then it's still warfarin, and it's complicated with these NOAC, the new drugs with they have this protein binding, and I don't think it's well studied enough to suggest that you would use that. So warfarin would be the long-term option for nephrotic patients with indication for treatment if they have a low plasma albumin.
Okay, thank you. Now, Eleni, the question is about if you have class 3 or 4 lupus nephritis, and in the induction phase, you give them IV cyclophosphamide. What kind of steroid dose would you start your patients on? The question is about that. And actually, they're asking about, would you give 0.8 milligrams to 1 milligram per kilogram? And the other question comes, if you're using the Eurolupus regimen, what is the period that you're going to taper the steroid down? And finally, the third one, how long would you treat your lupus nephritis patients for the maintenance after controlling or finishing the induction therapy? Okay, thank you.
Okay, so regarding the first question, if induction therapy starts with cyclophosphamide, then the steroid dose, then I would continue with azathioprine. I could continue with azathioprine. And regarding steroids, actually, if we're talking about rapidly progressive glomerular disease, I would start with prednisolone pulses to minimize inflammation rapidly. And then I would certainly try to reduce cumulative steroid dose. Therefore, I could start with 0.6 milligrams per day. I wouldn't use 20 milligrams as starting prednisone dose, but I would certainly taper steroids fast. I would, by 12th week, go down to 7.5 milligrams per day.
If we're using the Euro lupus regimen, how long will it take us to taper down the steroids? How long do you think give steroid therapy?
Okay, again, I would use the same tapering scheme. Attempts in all these guidelines are to reduce cumulative steroid doses because they have serious side effects. Okay, so again, I would use the same tapering regimen. And regarding, for the third question, regarding maintenance therapy, the exact duration of maintenance therapy at itself is not known and is not studied. Perhaps I would withdraw steroids after 12 months in complete renal responders and without ongoing extrarenal manifestations, but I would keep total therapy for at least 36 months because a histological activity may be still present despite 12 months of complete renal response. So at least 36 months of treatment. And I would add that in the ERA DTA guidelines that were published last year, recommendations, they suggest up to 5 years of total therapy, far more than these guidelines recommend now. Thank you.
Okay, thank you. Now some questions to Vladimir. One of them is actually about the treatment duration with rituximab in your ANCAS vasculitis patients as well. But one of the interesting questions is about, would you treat MPO versus PR3 patients differently in your regimen? How would you start the induction therapy, and for the maintenance, how would you go, how long would you go ahead? And the other one is, what is the real dose of rituximab if we're going to continue with rituximab treating our patients?
So each of these questions is completely based on opinion because we have almost no evidence on that. So concerning the maintenance with rituximab, we use the same regimen which we adopted based on the experience of David James from Cambridge. So we start with 2 doses of 1 gram 14 days apart as induction, and then proceed with 1 gram each 6 months until 2 years. And we usually finish after 2 years. But in some patients who are anti-PR3 positive, still remain positive, still have some gambling disease, we proceed. And we have now some patients who are in B-cell depletion for more than 5 years, but this is not common. Commonly, we interrupt the treatment and start it once again when there is once again some activity. But there are some other regimens, such as giving lower doses more frequently, or probably it's quite enough to give 0.5 grams each 6 months, or you can give 0.5 grams each 4 months. So there are several options. It's something which is based more on local experience or local habits than on really evidence. And there was also a question about the different treatment of anti-PRC and anti-MPO patients. Of course, I think that there are accumulating evidence that these patients should be treated in different way. But the problem is that once again, we have no data from randomized controlled trials, because in randomized controlled trials, there were in all these trials, the patients who were anti-PRC positive and anti-MPO positive were mixed together. And so it means that it is also once again based on mostly opinion. But it seems that, of course, in anti-MPO patients there is much lower risk of relapses. So the maintenance treatment should not be so long. And some our colleagues, such as our friends from Mayo Clinic, such as Fernando Fervenza, suggest not to treat them with maintenance treatment at all. Possibly it can be done in some patients under close. And in anti-PRC patients, many of them are at high rate or high risk of relapses and must be treated for a longer time and with higher doses of
Okay, thank you. Now the question goes to all of you, actually. I have received a couple of questions inquiring about the use of Rituximab in any of those patients that we were discussing during the COVID era. And I know that Annette was talking about cases, and I even have some cases as well. So let's hear about your comments with the use of this Rituximab in the COVID era. Thank you.
So I can just say that we were very afraid at the beginning of this
pandemic. If I can respond, I
Yeah.
don't know if you hear me now.
Yeah, we hear you. Yeah. So we were very afraid about at the beginning of the pandemic, and then our rheumatology colleagues, they said, "Why are you so afraid? We just continue treating the RA patients." And then I sort of realized that the difficulty we had was perhaps not so much about the treatment, but about the CKD, because CKD patients have a much higher risk of infection and bad outcome. So we sort of restarted again in the patients we thought that absolutely needed Rituximab. But the one thing that I have been thinking a lot about is, what do we do when we have a good vaccine? Because Rituximab affects antibody levels, and we have to think about that for the future, what we do. But I think that we should treat the patients the best way we can, and then consider potential aspects for the future. But CKD is probably the hard issue here, for which puts our patients at risk.
There are not yet published data from Scotland suggesting that Rituximab is not associated with higher risk of severity of COVID-19 infection, and that the patients who are at risk are the patients with pulmonary involvement in the history, and also the patients treated with high-dose corticosteroids. And concerning my own experience, we tried to postpone Rituximab in some patients who still were in at least partial remission, had no activity of the disease, but many patients were treated during the spring and the summer. And now one of our patients died doing B-cell depletion, being given Rituximab for the last time very early. I think it was in June. But at that time, because of alveolar hemorrhage, so he had to be treated in some way. And of course, the question is, what was the reason? Because it was probably mostly bacterial superinfection. And what we discussed in detail was the use of convalescent plasma in these patients who have no antibodies against the virus. And probably it may be meaningful in some of these patients.
Eleni, any comments from you? Any patient's experience?
Okay, so I agree with both speakers. I would say that we could delay Rituximab, but we have to give it anyway. Of course, results are needed from studies, and I only hope that finally we have this vaccine against COVID, and then we will decide what our next immunosuppression in our patients will be.
All right, thank you. And actually, we had one patient, a membranous nephropathy patient, who had been already administered Rituximab a couple of days before we discovered that he came in with COVID-19. So he was hospitalized. This was March, and we did well with him, and we presented as one of the first cases who has been treated with Rituximab. I totally agree with you, especially with the vaccination coming in, with the antibodies going on. And anyway, we'll see what's going to happen in a couple of weeks. Every day we have new information, and we try to change our treatments according to the data that is gathered. And I know that the kidney community, the ISN, is also working on getting our experiences the data, and we will be sharing it with the ISN community and the nephrology community as well.
Well,
Anyway,
I have one.
Yes,
I
okay.
have one case. So I had
Okay.
this one patient who was, I think, in the MyPsych trial. So he was still on mycophenolate forever, and then he was had this grumbling disease, and I wasn't really happy about his treatment. I was thinking of giving him rituximab instead. And before I could do that, he ended up in the hospital with a really bad case of COVID, and they called me. And there was like a lot of conflict about what you should give the patients, and it was a big mess the whole spring. But he ended up with a neurologist because they had to open the ward. So then I called them. I said, well, you should give him a little bit more steroids because he was really inflamed. And then I said that maybe you could give him tocilizumab because that could perhaps help. And after that, he just responded really well, and he became ANCA negative for the first time. I don't know how many years, but now he's been given his first rituximab maintenance therapy after this. This was like in May or something. But I really didn't know what to do. But I think that more immunosuppression when he was hyperinflamed actually saved him. So, and tocilizumab has been used for ANCA vasculitis in case series, so it would be perhaps a possibility in those patients.
Yes, indeed. Anyway, I want to thank all of you for being with us. And I want to thank my speakers. And if we haven't answered all of your questions, I will forward them to the related speakers, and we will try to get back to you. And we hope to see you at another webinar. And thank you once more being with us this evening, afternoon, and hope to see you face